This is a NCLEX tips and points video on acute respiratory failure. We need to know about various risk factors for acute respiratory failure. There are mainly three classifications, which includes impaired ventilation or hypoventilation. The next is ventilation perfusion mismatch, and the third one is impaired diffusion, or it is the alveolar type. The risk factors which is included in impaired ventilation or hypoventilation are airway obstruction, respiratory muscle weakness or paralysis that can occur with neuromuscular disease such as myasthenia gravis, chest wall injury, anesthesia, and opioid administration. The ventilation perfusion mismatch as a risk factor for acute respiratory failure occurs in COPD, restrictive lung diseases such as sarcoidosis, pulmonary fibrosis, atelectasis, pulmonary embolus, and pneumothorax. Impaired diffusion occurs in pulmonary edema and acute respiratory distress syndrome, ARDS. The clinical manifestations of respiratory failure are classified into three: early, intermediate, and late. The early manifestations include dyspnea, restlessness, anxiety, fatigue, increased BP from baseline, tachycardia. The intermediate clinical manifestations include confusion, lethargy due to increased carbon dioxide, and pink skin coloration due to increased carbon dioxide. The late manifestations include cyanosis and coma. These are points which you need to know when you get questions on NCLEX-RN. Normal ventilation is stimulated by the buildup of carbon dioxide in the blood. Chemoreceptors detect a hypercapnic, that is the elevated carbon dioxide state, and the respiratory cycle is stimulated to breathe faster and more deeply. This is called the hypercapnic drive. This happens in all normal people. In some patients with COPD, the body's chemoreceptors become less sensitive to carbon dioxide because it is retained at higher levels as a result of the disease process. Over time, the patient with COPD develop a hypoxic drive to breathe. It is the lack of oxygen in the blood that causes these patients to breathe. It is because of this hypoxic drive that patients with non-COPD may not tolerate high oxygen concentrations when being given supplemental oxygen therapy. The increased amount of oxygen may cause the patient to stop breathing. Careful continuous monitoring must be used when providing increased oxygen level to these patients. Hope you understood this video. Keep watching for further videos.